This video discusses topics related to mental health and psychiatric conditions for educational purposes only. The content is intended as a learning tool for medical students preparing for licensing exams and is based on high-yield academic material. This is not medical advice and should not be used to diagnose or treat any condition. If you or someone you know is experiencing mental health concerns, it is important to seek help from a qualified healthcare professional. Support is available, and you are not alone. In this video, we will review high-yield psychiatry cases focused on anxiety disorders, learning mechanisms, personality disorders, and neurocognitive conditions. Case 1: we have a 30-year-old woman with overwhelming anxiety and stress. She has had increasing job-related pressure over the past 6 weeks. She reports sudden episodes where she becomes very nervous and then feels shaky, dizzy, and nauseated, followed by sweating. One episode occurred while speaking with her boss. She is especially worried about having an episode during work meetings, but these episodes have also occurred while she was relaxing at home. Because of this, she has stopped seeing her friends, as she never knows when the symptoms will appear. She has no significant medical history and does not use alcohol or drugs. Her vital signs are normal, and both physical examination and laboratory evaluation show no abnormalities. The question is, what is the most likely diagnosis? The correct answer is panic disorder. This patient has recurrent episodes of acute anxiety accompanied by physical symptoms such as shaking, dizziness, nausea, and sweating. These are characteristic features of panic disorder. The diagnosis requires recurrent, unexpected panic attacks that reach a peak within minutes, followed by persistent concern about future attacks or changes in behavior to avoid them. Patients often restrict their activities due to fear of having another episode. Physical symptoms may include chest pain, shortness of breath, tachycardia, as well as gastrointestinal and neurological symptoms. A key feature is that some attacks occur spontaneously without a clear trigger, such as when the patient is relaxing at home. For diagnosis, it is important to rule out medical and substance-related causes, such as hyperthyroidism and alcohol withdrawal. Panic disorder should also be differentiated from other psychiatric conditions where panic attacks are triggered by specific situations. Acute stress disorder involves exposure to a traumatic event, followed by symptoms such as re-experiencing, avoidance, and hyperarousal, lasting from 3 days to 1 month. Adjustment disorder with anxious mood is associated with an identifiable stressor, but symptoms do not meet criteria for another mental disorder. In this case, the presence of unexpected panic attacks makes panic disorder more likely. Generalized anxiety disorder involves excessive worry for at least 6 months about multiple areas such as work, health, or finances. In contrast, panic disorder is centered on recurrent unexpected panic attacks and fear of future episodes. Social anxiety disorder involves panic symptoms triggered by social situations, with a strong fear of negative evaluation by others. Case 2. A 30-year-old graduate student with a history of recurrent ear infections during childhood feels anxious and begins to sweat when she is in the examination room with her physician. She recently got a roommate who is a nursing student and leaves her stethoscope on the coffee table. After returning home from class, the patient notices that whenever she sees the stethoscope, she begins to sweat and feels her heart racing. The question is, what is the most likely explanation for this response? The correct answer is classical conditioning. This patient's reaction to the stethoscope is an example of classical conditioning. During childhood, visits to the physician for ear infections acted as an unconditioned stimulus, producing anxiety. These medical encounters were repeatedly associated with the presence of a stethoscope. Over time, the stethoscope became a conditioned stimulus. Classical conditioning also explains white coat hypertension, where a physician's white coat